Acute transverse myelitis. Param Vidwan. March 7, 2008 Morning Report. Know thy terminology. Myelopathy, SNES dysfunction due to a lesion, 1, within the spinal cord, inflammatory or demyelinating lesions, cord infarction, vitamin B12 deficiency, copper deficiency, etc., or, 2, compression of the cord, epidural tumors, epidural abscess, cervical or thoracic disc. Transverse myelopathy, clinical presentation of severe motor, sensory, and autonomic dysfunction due to any process affecting spinal cord. Transverse myelitis, when myelopathy is due to an inflammatory or demyelinating lesion. Transverse myelopathy. Transverse myelitis. SNES dysfunction due to anything. Clinical findings suggesting problem at spinal cord level. When transverse myelopathy is due to itis. SLE, schistoidosis, post-vaccination. Epidemiology. Transverse myelitis is a rare syndrome with incidence of between 1 and 8 new cases per million people per year. ATM in SLE is a very rare manifestation. A prevalence of less than 1% has been estimated, and only about 105 cases are reported in the literature. Berman M., Feldman S., Alter M., et al. Acute transverse myelitis, incidence and etiologic considerations. Neurology. 31 to 966 to 971. Kovacs B., Lafferty, Brent L.H., et al. Transverse myelopathy in systemic lupus erythematosus, an analysis of 14 cases and review of the literature. Ann Romdis 2000, 59, 120-4, Pathogenesis of acute transverse myelitis. Short answer, nobody knows. However, some historical clues. Osler in 1892, acute post-infectious polyneuritis. Molecular mimicry. A characteristic component of human neural tissue is sialic acid, which is found in neural cell walls. Sialic acid is also found as a surface antigen on C. jejuni within its lipopolysaccharide outer coat. Antibodies that cross-react with gangliosides from C. jejuni. Pathogenesis of acute transverse myelitis. In 1922, physicians in England and Holland observed post-vaccinal encephalomyelitis after polio vaccination. Autoimmune process resulting in ATM. Autopsy evaluation of the spinal cord revealed severe axonal loss with mild demyelination and a mononuclear infiltrate, predominantly T lymphocytes and nerve roots and spinal ganglia. Vidwan's hypothesis. Vasculitis. Disruption of BBB. Lymphocytic infiltration. Vascular occlusion. Coagulopathy due to inflammation /APLA. Autoimmune. Occlusion leads to ischemic necrosis. Ontoneuronal ab. Vasculitis, disruption of BBB. Infiltration of lymphocytes. Vasculitis and APLA increase risk for coagulopathy, vascular occlusion and ischemic necrosis. Autoimmune, ontoneuronal antibodies. Inflammation and thrombus leads to demyelination and necrosis. Vasculars. Disruption of blood-brain barrier. Lymphocytic infiltration. Perivascular inflammation. Thrombi. Inflammation and thrombus leads to demyelination and necrosis, which then causes radiological and clinical manifestation. Vasculitis, disruption of BBB. Infiltration of lymphocytes. Vasculitis and APLA increase risk for coagulopathy, vascular occlusion and ischemic necrosis. Autoimmune, ontoneuronal antibodies. Diagnosis. Systemic lupus erythematosus, SLE, is a systemic disease that can affect any organ system in the body. Central nervous system involvement is reported in 24% to 51% of cases. Common SNES manifestations of SLE include CVA, seizure, psychosis, depression, aseptic meningitis, cognitive dysfunction, and headaches. Longitudinal myelitis as an initial manifestation of systemic lupus erythematosus. American Journal of Medical Sciences. 2004 February, 327 105-8. Review. SNES manifestation of SLE by prevalence, least to most. Autonomic neuropathy, 10%. Seizures, 10 to 20%. CVA, 19%. Mood disorder. Headache, 50%. Cognitive decline, 80%. Stroke 19%, cognitive decline up to 80%, headache, migraine or tension. CVA. Accelerate atherosclerosis. Antiphospholipid. Hypertension. Psychosis. Acute transverse myelitis. Presentation of ATM in SLE. 50% of patients have motor deficits involving lower extremities. Virtually all patients have some degree bladder or bowel dysfunction. Autonomic symptoms vary from increased urinary urgency, to bowel or bladder incontinence, difficulty to void, incomplete evacuation or bowel constipation. 80 to 94% have numbness, paresthesia or band-like dysesthesia. Christensen led, Wormuthel, Hinge H. et al. Clinical course and long-term prognosis of acute transverse myelopathy. Actin Neuroscanned. 1990 /81 to 431 to 435. Idiopathic acute transverse myelitis criteria. From Kerr Open Neural, Volume 15-3. June 2002.339 to 347. Differential diagnosis. Differential diagnosis of transverse myelopathy in patients with SLE includes medulla compression caused by vertebral fractures, epidural or subdural hematoma, epidural and or paraspinal abscess complicating disc space infection, disc herniation, intra and extramedullary tumor, multiple sclerosis, MS, infection, Guillain-Barré syndrome, neuromyelitis optica, acute disseminated encephalomyelitis. Treatment. Intravenous, 4-pulse-methylprednisolone and cyclophosphamide. It is unclear whether plasmapheresis has any additional therapeutic benefit. Poor prognosis. A 1989 review revealed 44 reported cases of SLE-ATM. Of these, only 26%, recovered either full or partial neurologic function. Others remained static, worsened, or died. Kovacs B., Lafferty, Brent L.H., et al. Transverse myelopathy in systemic lupus erythematosus, an analysis of 14 cases and review of the literature. Anne Romdis 2000, 59, 120-4. Proper DJ, Bucknell R.C. Acute transverse myelopathy complicating systemic lupus erythematosus. Anne Romdis 1989, 48, 512-5. 78-year woman evaluated in ED for worsening of left hemiparesis, which was caused by a stroke 2 years earlier. The stroke involved the right middle cerebral artery territory and was attributed to atrial fibrillation. Initially, she had a very severe left hemiparesis, but gradually improved with 3 months of rehabilitation. At her most recent office evaluation, she had a very mild left central facial palsy, a left pronator drift, and a left foot drop. Today, she awoke and realized that she could not walk due to increased weakness, which has now persisted for several hours. Her current medications are warfarin and metoprolol. Vitals, BP, 110/70, HR, 18, temp, 38.1. Physical exam, irregular heart rhythm. Neurological exam reveals normal mental status, normal visual fields, moderate left central facial palsy, and moderate left hemiparesis. INR is 2.3. Chem7 is normal. CT of brain shows a chronic hyperdensity in the right middle cerebral artery territories. Which of the following is the most likely diagnosis? Acute cerebral infarction, due to underlying A.Fib. Seizure. Unmasking of chronic deficit due to infection. Hemorrhagic stroke. A 64-year woman is evaluated in the ED for a 4-day history of progressive leg weakness and numbness and a 1-day history of urinary incontinence. She also had increasingly severe mid-back pain for the past 2 months. She has a HX of breast cancer diagnosed 2 years ago, treated with surgery and local radiation. Physical exam, normal mental status and cranial nerves. Strength in the arms is normal. Legs are diffusely weak. Sensory exam shows diminished pin sensation from the nipples downward. Vibratory sense is severely diminished in the feet. Anal sphincter tone is diminished. Which of the following is the most appropriate diagnostic study at this time? CT of lumbar spine. MRI of lumbar spine. MRI of entire spine. MRI of brain. Electromyography and nerve conduction study.